So our next topic is good Pasture syndrome, which is the fourth cause of acute kidney injury. The first and the most common is acute tubular necrosis. Second one is interstitial nephritis. Third one is rhabdomyolysis, and the fourth one is good Pasture syndrome. Good Pasture syndrome is an autoimmune disease in which antibodies are formed against the basement membrane of alveolar epithelium and the basement membrane of the glomerular basement membrane. So the person will present to you with hematuria and hemoptysis because of the formation of antibodies against the basement membrane in the glomerular epithelium and the basement membrane in the alveolar epithelium in the lungs. So the presenting features will be hematuria plus hemoptysis. Hematuria and hemoptysis. In kidneys, the good Pasture syndrome can cause a rapidly progressive glomerulonephritis. So good Pasture syndrome basically present to us with the features of acute kidney injury because it causes rapidly progressive glomerulonephritis. It is rapidly progressive, that's why it can cause acute kidney injury and not chronic kidney injury. So the fourth cause of acute kidney injury is good Pasture syndrome, which is a combination of rapidly progressive glomerulonephritis, which will manifest as hematuria and impaired renal function test. And the second thing that it can cause is it can cause pulmonary alveolar hemorrhages. How we will confirm a diagnosis? Someone presenting with features of hematuria and hemoptysis. The initial investigation that we'll do is a blood test. The most initial test is anti-GBM antibodies. And remember that the definitive investigation or the definitive diagnosis of any type of glomerulonephritis is made on kidney biopsy. So if you want to make a definitive diagnosis of any type of glomerulonephritis, then the definitive investigation will be kidney biopsy, which in case of good Pasture syndrome will show mesenteric glomerulonephritis because it involves the lungs as well. So a chest X-ray or a CT scan of the lungs will show a patchy infiltration due to intrapulmonary bleeding or hemorrhages. There will be patches of infiltration. So the initial in case of lung disease is chest X-ray, and the definitive is lung biopsy. So this was the fourth cause of acute kidney injury, and that was good Pasture syndrome that present to us with hematuria and hemoptysis. And it present with the features of acute kidney injury. Now, there are some other diseases which can present with hematuria and hemoptysis, or there are some other organ involvement. So in good Pasture syndrome, there is hematuria and hemoptysis. The initial investigation is anti-GBM antibodies, and the definitive is kidney biopsy, which will show mesenteric glomerulonephritis. Now, if a same person present to us with the features of good Pasture syndrome, such as hemoptysis and hematuria, plus there are two other features, and that are cannot see and cannot hear. So a person with features of good Pasture syndrome, such as hemoptysis and hematuria, and plus there is involvement of the air in the form of sensory hearing loss, and involvement of the eye, cannot see or cannot hear. Good Pasture syndrome plus cannot see plus cannot hear. The diagnosis will be Alport syndrome, which is an X-linked disorder, a genetic disorder. Now, hemoptysis. Hemoptysis with jaundice, involvement of liver and lungs. The diagnosis will be alpha 1 antitrypsin deficiency. Hematuria with features of asthma or eosinophilia and a positive P-ANCA. The diagnosis will be Churg-Strauss syndrome. So hematuria with hemoptysis, the diagnosis will be Goodpasture syndrome. Hematuria with asthmatic features, the diagnosis will be Churg-Strauss syndrome. And hematuria with upper respiratory problems such as sinusitis, nasal septal perforation, and epistaxis. The diagnosis will be Wegener granulomatosis. I'll repeat this point. Hematuria with hemoptysis, diagnosis is Goodpasture syndrome. Anti-GBM antibodies positive, and kidney biopsy will show mesenteric glomerulonephritis. Hematuria with asthma or eosinophilia, the diagnosis will be Churg-Strauss syndrome. Eosinophilic granulomatosis with polyangiitis is the other name for Churg-Strauss syndrome, and there will be a positive P-ANCA. Hematuria with upper respiratory problems such as sinusitis, nasal septum perforation, and epistaxis with a positive C-ANCA antibody. The diagnosis will be Wegener's granulomatosis, or the other name is granulomatosis with polyangiitis. So Churg-Strauss syndrome is eosinophilic granulomatosis with polyangiitis. And Wegener's granulomatosis is just granulomatosis with polyangiitis. There is no eosinophilia or asthmatic features. Hematuria after diarrhea, that is initially watery and then turns into bloody diarrhea. The diagnosis that you will suspect is hemolytic uremic syndrome. So these were the different causes of hematuria along with the lungs involvement, upper or lower respiratory tract involvement. So the next thing that can cause acute kidney injury is tumor lysis syndrome. So the fifth cause of acute kidney injury is tumor lysis syndrome. Is it clear, everyone, up till now? Is there any question? So who will tell me hematuria with asthma? What is the diagnosis?
Churg-Strauss eosinophilic granulomatosis with polyangiitis.
Yes, Churg-Strauss syndrome. Hematuria with nasal perforation.
Wegener's granulomatosis.
And which is the antibody that is positive in Wegener's granulomatosis?
Is it the P-ANCA? Sorry, ANCA.
C-ANCA.
Yeah, C-ANCA.
Hematuria, hemoptysis, and cannot see and sensory hearing loss. What is the diagnosis?
Alport syndrome.
Yes, Alport syndrome. So which glomerulonephritis can cause acute kidney injury?
Good Pasture.
Good Pasture syndrome cause which type of glomerulonephritis?
Rapidly progressive glomerulonephritis.
Yes, that's right. Rapidly progressive glomerulonephritis is caused by the good Pasture syndrome, which can present as with the features of acute kidney injury. So far we have discussed four causes of acute kidney injury. First of them was acute tubular necrosis. Second was interstitial nephritis. Third was rhabdomyolysis, and fourth is good Pasture syndrome, which causes rapidly progressive glomerulonephritis. Now, a fifth cause, and that is tumor lysis syndrome. Whenever a person has tumor lysis syndrome, is basically a complication of mostly blood cancers, but it can be associated with solid tumors as well. It is usually caused after chemotherapy, because chemotherapy results in the killing of a large number of tumor cells. So it is associated with most commonly with blood malignancy, and it can occur after a chemotherapy session. So what will happen when there is lysis of a tumor cells? Whenever there's a lysis of the tumor cells, again potassium will be released, which can cause hyperkalemia. And the other thing that is released from a dying or if a lysed tumor cell, that is nucleic acid or DNA. Nucleic acid is converted into the uric acid, and uric acid can lead to damage to the kidney tubules and result in acute kidney injury. So tumor lysis syndrome can also cause acute kidney injury due to hyperuricemia because nucleic acids are released by the dying cells or the lysed tumor cells, which are converted into the uric acid. So that's why tumor lysis syndrome can also cause acute kidney injury. The management is same as IV fluid hydration and treating the hyperkalemia. So this was the fifth cause of acute kidney injury. Now, sixth cause of acute kidney injury, that is contrast-induced nephropathy. Contrast are used mainly in CT scan studies, or in other studies contrast are also used, such as in angiography. Contrast are also used. So any study that involve the use of a contrast can cause acute kidney injury, because the contrast media that are used during these studies, they are nephrotoxic and they can damage the kidneys. How we can avoid the contrast induced kidney damage? First of all, we need to advise the patient to drink plenty of fluid before and after the study. And we need to take the medication history. And if he or she is taking any nephrotoxic drug, such as NSAIDs or metformin, then we need to advise the patient to stop taking these drugs. So either we can advise him to drink plenty of fluid before and after the study, or we can give him IV fluid with normal saline before and after the contrast study. So this was the sixth cause of acute kidney injury. So we are done with the acute kidney injury and its causes. So who will repeat the definition of acute kidney injury? Who will define acute kidney injury?
It is raised creatinine plus reduced urine output, leading to renal failure.
Yes, how much raised creatinine?
That would be 26.5
Yes, 26.5 or more than
or more.
26.5 in
Yeah.
48 hours, or a raise of 50% or more than 50% in the 7 days. And what about on the urine output? How much reduce in urine output?
Below 0.5 mil per kg for 6 hours.
Yes. So who will tell me 6 causes of acute kidney injury? Starting from the most common cause and then moving down with the less common causes.
So first is the acute tubular necrosis. Second is interstitial nephritis.
Yes.
Third is rhabdomyolysis. And
Yes.
then it's good pasture.
Yes.
And then there are a few more like other causes like Alport syndrome, alpha antitrypsin deficiency, Shock-Strauss syndrome, venous granulomatosis, hemolytic urinary syndrome, and tumor lysis syndrome.
Yes.
And the contrast is
Lysis
nephropathy.
syndrome and hemolytic uremic syndrome can also present as in AKI. But the only glomerulonephritis that present with the features of AKI, it's a good Pasture syndrome.
Good pasture. And the sixth one is
The
contrast
other
with
one can cause, yes, contrast-induced nephropathy. So what causes acute kidney injury in tumor lysis syndrome?
it's a breakdown of the tumor cells, or if there is a malignant blood cancer. Then
What is the mean metabolite that can cause acute kidney injury in tumor lysis syndrome?
so after chemotherapy, there will be killing of the tumor cells, and there will be increased potassium release, and the nucleic acid will be converted to uric acid that leads to damage to the kidney. And
Yes, hyperuricemia in tumor lysis syndrome is the cause of acute kidney injury. So, along with IV fluids in acute kidney injury due to tumor lysis syndrome, we can give a drug that inhibit the synthesis of uric acid, that is febuxostate. So this was all about acute kidney disease. Now we are going to discuss chronic kidney disease. So chronic kidney disease is a chronically reduced EGFR or a proteinuria. So chronic proteinuria or chronic reduction in renal function over a period of for at least 3 months is known as chronic kidney disease. Proteinuria, that is ACR of more than 3 milligram per millimole for at least 3 months, define chronic kidney disease. And EGFR less than 60 ml per minute for at least 3 months. So these are the 2 criteria to define chronic kidney disease. One is EGFR of less than 60 ml per minute for at least 3 months, and ACR albumin creatinine ratio greater than 3 milligram per mole per millimole for at least 3 months. Now, some findings in the chronic kidney disease. So what are the functions of the kidney? The function of the kidney, the most important function of the kidney is water and electrolyte balance. So whenever there is a chronic kidney disease, problem will occur with water and electrolyte because kidneys are involved in the water and electrolyte balance. So there will be imbalance of water and electrolyte if a person develops chronic kidney disease. What will happen? The person can develop pulmonary edema or peripheral edema because of decreased excretion of water due to chronic kidney disease. And the second thing, so what are electrolytes are excreted by the kidneys? There are two important electrolytes that are excreted by the kidneys. One is potassium and the other one is hydrogen ion. So whenever there is a chronic kidney disease, these two electrolytes, that is potassium and hydrogen ions, they are not excreted. So hyperkalemia and metabolic acidosis can result due to imbalance in their excretion. So a patient with CKD can have uh, peripheral edema or pulmonary edema or even ascites due to decreased excretion of water. And the second thing that he can have is hyperkalemia and metabolic acidosis due to decreased excretion of potassium and hydrogen ion. And now we all know that erythropoietin is released by the kidney tubules or kidney cells. Erythropoietin is involved in the formation of red blood cells. And another hormone that is released or whose active form is formed in the kidneys, that is vitamin D, which is involved in the absorption of the calcium from the kidneys and from the intestine. So three abnormalities were related with water and electrolyte imbalance, and two are related with endocrine function of the kidney, that is decreased erythropoietin production will lead to anemia, and decreased active form of vitamin D lead to low calcium and high phosphate. And this low calcium can stimulate the production of PTH, parathyroid hormone. So secondary hyperparathyroidism can also be present in CKD or chronic kidney disease. So now itching is a common feature of chronic kidney disease due to increased serum urea and serum phosphate levels in a patient with chronic kidney disease. The person may feel itching after taking a hot shower. So it is one of the differential diagnoses of itching after hot shower, that is chronic kidney disease. Itching after hot shower can occur in chronic kidney disease due to increased serum urea and increased serum phosphate. What are the other features that will help you differentiate it from the other causes of itching after hot shower? Remember three things or three disorders that can cause itching after taking a hot shower, and that is a CKD, and the second one is polycythemia rubra vera, and the third one is scabies. So how you are going to differentiate between these three things or three disorders that a person will present to you with itching after hot shower? So if there are feature of anemia are present as well, such as tiredness or pallor, the patient is pale and he or she is having itching after hot shower, and there is peripheral edema and hyperpigmentation, then these features points towards chronic kidney disease or chronic renal failure. While in case of polycythemia rubra vera, because of increased formation of RBCs, the person will be red. There will be facial plethora, and not the person will not be pale, as in case of chronic renal failure. And because the viscosity of the blood is increased in the polycythemia rubra vera, so the person will also complain of burning of arms and sore. So itching after hot shower and the patient is pale and there's peripheral edema, your diagnosis will be chronic renal failure. And itching after hot shower and the patient is red and he is also complaining of burning of the palms and sole, and because the blood is thick or the viscosity of the blood is increased, so the person can have stroke as well. There is splenomegaly as well. And the third one, itching after hot shower, and there are linear tracks on skin or boros on skin, then your diagnosis will be scabies. So this is how you can differentiate between three causes of itching after hot shower. So we were discussing features of chronic renal failure. So a person with chronic renal failure due to water and electrolyte imbalance can develop peripheral edema. Due to anemia, he can complain of tiredness, and due to raised serum urea and phosphate, he will complain of itching after hot shower. Liver failure can also present with itching, but in liver failure, serum bilirubin will be raised, and other features of liver failure that we discussed in the gastroenterology chapters, such as ascites, and because of less formation of the clotting factor, bleeding can also occur in liver failure. So itching with raised serum bilirubin and ascites, the diagnosis will be liver failure. We all know that vitamin D deficiency can occur in CKD. The cause of vitamin D deficiency in CKD is that uh, this is a normal formation of the vitamin D. The sunlight, the first molecule is formed, and that is cholecalciferol, is formed in the skin by the sun. That is, cholesterol metabolites are converted into vitamin D, and then this vitamin D is hydroxylated, or first hydroxylation of cholecalciferol occur in the liver, and 25 hydroxy cholecalciferol is formed in the liver. So hydroxylation at 25 carbon occurs in the liver. Then this 25 hydroxy cholecalciferol, the second hydroxylation occur in the kidneys. So if the patient is having a liver disease, he will have a deficiency of vitamin D. And if the patient is having a kidney disease, because the second hydroxylation occur in the kidney, and after second hydroxylation, the molecule of hydroxy cholecalciferol become dihydroxy cholecalciferol, which is an active form of vitamin D, also known as calcitriol. The function of vitamin D or calcitriol is increased intestinal absorption of calcium. So someone has a kidney disease or liver disease, he will have a deficiency of vitamin D, and due to deficiency of vitamin D, his serum calcium level will be low. And this reduced serum calcium leads to an increase in the PTH secretion, which is known as secondary hyperparathyroidism. So we can say that in short, the patient with CKD will have hypocalcemia or low calcium level, which can lead to secondary hyperparathyroidism. So why there is hyperpigmentation in chronic kidney disease? There is hyperpigmentation result from an increase in melanin production because of an increase in poorly dialysable beta melanocyte stimulating hormone. Because beta melanocyte stimulating hormone is not excreted by the kidneys, it stimulates the increased melanin production, which can lead to hyperpigmentation in chronic kidney disease. So what is the management of chronic kidney disease? along with the management of the complications such as acidosis, hyperkalemia, fluid overload. There are drugs that can slow down the progression of the chronic kidney disease. So the two important causes of chronic kidney disease are hypertension and diabetes. Other than hypertension and diabetes, other things that can cause chronic kidney disease, they include membranous nephropathy, which is a cause of nephrotic syndrome. So glomerulonephritis, hypertension, and diabetes, they can cause chronic kidney disease. Hypertension and diabetes are the two most common causes. So along with managing the complication of chronic kidney disease, what we can do to slow down the progression of chronic kidney disease into end stage renal disease. The drugs that slow down the progression of chronic kidney disease, they are ACE inhibitors, angiotensin converting enzyme inhibitors, or ARBs. Both of them has the same function. Uh, any of them can be given, either an ARB or an ACE inhibitor can be given. If someone does not tolerate an ACE inhibitor, such as he developed dry cough with ACE inhibitors, then we can prescribe him ARBs. ACE inhibitors include all the drugs that end in pril, such as captopril, lisinopril, and ARB include the drugs that end in TAN, such as valsartan, telmisartan, etc. So any of them can be used to slow down the progression of CKD. So what is the criteria to prescribe ACE inhibitors to patient with chronic kidney disease to slow down its progression? If someone has diabetes and his ACR is 3 or more than 3, if someone has hypertension and his ACR is 30 or more than 30, and any chronic kidney disease with ACR 70 or more than 70, then we need to start either an ACE inhibitor or an ARB.
Sorry, sir. Could you repeat that again?
So CKD of any cause other than hypertension or diabetes, the criteria to start an ACE inhibitor or an ARB is if ACR is 70 or more than 70. And CKD due to CKD with hypertension, the threshold to start ACE inhibitor is ACR of 30 or more than 30. And CKD with diabetes, ACR of 3 or more than 3 is the indication to start ACE inhibitor or ARB. So this was all about chronic kidney disease, which can be caused by hypertension, diabetes, and glomerulonephritis, such as minimal change disease or membranous glomerulonephritis. The next topic is pyelonephritis. So is it clear everyone up till now? Or is there any question? Okay. So our next topic is pyelonephritis. Pyelonephritis is infection of the kidneys or upper urinary tract is known as pyelonephritis. What are the contributing factors that can lead to pyelonephritis? They are pregnancy, stone, vesicoureteric reflex, and diabetes. All of them are risk factor for developing a pyelonephritis. Lower UTI means infection of the urinary bladder or urethra, which can present with features such as dysuria, frequency, urgency, and lower abdominal pain and fever. So these features are called lower UTI features, such as dysuria, frequency, urgency, lower abdominal pain, and fever. If along with these features, two other features such as rigors or loin or back pain, or a pain at costovertebral angle, or tenderness at costovertebral angle, which is also known as renal angle. So if these two features are present, then we will say that the infection has ascended upward to the kidneys. That's why it is causing a loin or back pain or a pain at renal angle. Then it will be known as pyelonephritis. So someone with a feature of lower UTI along with the rigors or loin or back pain or renal angle tenderness, the diagnosis will be pyelonephritis. So it is an infection of the kidney parenchyma. So what are the difference between acute pyelonephritis and chronic pyelonephritis? The difference between both of them is simple. Acute pyelonephritis will be present with the features that I mentioned, fever, rigors, and loin pain. And chronic pyelonephritis, due to recurrent UTIs, what will happen due to recurrent UTIs for a prolonged period of time, renal scarring occur due to damage and inflammation. Renal parenchyma is replaced by renal scars. So due to repeated UTIs, renal scarring occurs, which leads to smaller kidney size, and due to scarring in the kidneys, what will happen? Hypertension will also occur. So chronic pyelonephritis will present to you with hypertension plus renal scarring. Hypertension plus renal scarring due to repeated UTIs. These will be the features of chronic pyelonephritis. So if someone with a history of multiple or recurrent UTIs or pyelonephritis and he or she has hypertension, then the diagnosis will be chronic pyelonephritis. In chronic pyelonephritis, there is no active infection.